who go to your clinics, but a broader group, and raise questions there. And one of the issues I think is well illustrated here. This is a report that Dr. Hyler, who made in a medical journal, New Mexico. He described a homeless schizophrenic obese woman delivered by a paramedic urgently to the emergency department where he was working, drunk and suffering an acute myocardial infarction. So what did you do? Obviously, stent was placed earlier, several weeks earlier, had clotted. There had been arrangements to obtain medication free when she'd been discharged, but the patient couldn't manage the bus fare to pick it up. After weeks in the hospital, over 200,000, she survived and then was discharged back into the street. And I suppose one of the reasons I'm raising that is a sole focus on individuals' medical care may not necessarily be the best approach. And again, it's the issue of the system is perfectly designed to produce the results that you observe. The financing, the industries, the material interests that support this way of working. And there are changes happening with value-based funding, population health, and we'll go to some of that later. So, relating it more to your subject, this is, I think, a very good summary of thinking about multi-level influences on disparities in hypertension prevention and control. Very good paper. And this maps out how these different layers, these different environments, social, regulatory, financing, and ultimately work through family and social support to the individual patient level. And lists some of the factors that have some influence over hypertension prevention and control. And I would like University of Best Practice to consider some of these, this thinking and this research in that field, although I do understand why these are not front and centre of your work at the moment, and I'll come to that. Now, we know a lot more about the influences and explaining why things are the way they are than we do about which interventions can be used and which of these are effective. And there is a good argument for saying, well, actually it's better to stick with the interventions that are effective and the methods that are effective for delivering them. Hence, University of Best Practice, if we want to reduce heart attack and stroke. We know a medical intervention, and we have an infrastructure, University of Best Practice, which is a good way to improve uptake of those. And then there are all the different substructures within each health system and physician organisation group which do that. So what's wrong with just strengthening that approach? Better stick with and strengthen what we know is effective than go out on the limb and take risks in some of the other areas. What interventions would we use? We simply don't know enough about that. And I think that's an interesting and important argument, and I accept that. But I'll come back to that later and make some suggestions. So, the point that this public health guy from another country is making is unsustainable approach to health and healthcare. Run those figures ahead another 10 years and it gets ridiculous. Increasing disparities in health. I think over the last 10 years, certainly over the last 5, we've seen increasing gaps in health between ethnic groups, especially income groups, and I think there's the beginning problem of elder poverty and significant problems for older people in terms of
their income and lifestyle and other issues. And I can't see a lot that is going to make things better in the next 10 years in these particular areas. And this is going to put an increasing burden. I mean, normally it's a case of, well, that's their problem, but actually increasingly it will encroach on the middle class and the rich, because they in certain ways will be impacted by this. So you cannot isolate yourself from what is happening to poor people and those sleeping out. But as I've said, yes, all very virtuous and terrific, but are there effective interventions for these social determinants? And that's what I'll move towards now. And even if there are effective interventions, do we have an infrastructure for implementing these? Because these are often cross-sector, cross-services. They're really quite complicated to put together a number of interventions for those different levels of influence. So, evidence-based solutions. My focus now is going to turn to what's hindering our achieving these controls, and for those most at risk. This is both those that we see and can afford it, but also we need to think about people with limited assurance, where out-of-pocket payments are increasing considerably, co-pays and deductibles, as well as the uninsured and undocumented. And what I'm going to be focusing is on developing your new cooperative approach here. Does University of Best Practices provide a model, a beginnings of a cooperative approach that might then be extended and deployed to these other areas? And I think one of the issues is, well, actually, University of Best Practices, is it a sustainable embedded cooperation? And I think there are issues about that as well, which I'll come back to. So, first of all, a reminder, and I'm hoping this is a reminder. I'm assuming our group here know about Steve's research, the one that was just published. If not, there's no harm in mentioning it again very quickly. I mention it as I've come cold to this. I need to declare, I do know Steve from Steve Shortell, Department of Public Health, and the group that did this research, and I have a lot of time for their work. But I put my critical gaze on the data, and my initial reaction is, whoa, just a minute, time series data. This is a strong association, but you know, there are questions here about it. So what we've got is San Diego Right Care data. San Diego Right Care started, I think, earlier than that. We've got time series data over 7 years on hospitalizations, heart attack and stroke. So from where I'm coming from is, well, just a minute, there's obviously going to be an attribution issue here. How are we able to assess how much the universities of best practice in San Diego influenced the hospitalizations for heart attack and stroke? Because there are so many other things happening, not least of which there's the Kaiser bundles that they were implementing, which I know about from work with Kaiser.
So John, we did
Yes.
start the Right Care Initiative in San Diego in 2010 because we received an NIH GO grant in October 2009.
Yes.
So we started our pre-meetings and our ALL conference, etc. in 2010. And
In
that's
2010,
yeah.
yeah. Okay. What this group's data that involved researchers from RAND as well, high probability of heart attack reductions were due to the San Diego Right Care program. I'm assuming that people have seen this graphic. If not, this is an important one for those of you who want to put the case for this Sacramento Right Care Initiative. Let me take you through it. What we've got here is hospitalizations for heart attack, hospitalizations for stroke. University of Best Practice in San Diego starts, they put the start 2010. This is time series data for the years 2007, 2008, 2009, 2010, and San Diego County is this one. And what we see is over 3 years, a 7.6 reduction in hospitalizations for heart attack.
In the state.
In the state, for the mean for the state, sorry, median for the state, excluding San Diego County. So that would be the, as it were, the control comparison we're making. And we see a 23%, 24% drop. And that is statistically significant using difference within difference statistics on time series data. However, for stroke, it's not statistically significant, which is interesting, and we could spend a whole afternoon on discussing this. And the evidence for UBP is less for that, and in part it was because there was a spike in the number of strokes in San Diego 2010, which muddies the data, but the actual trend is also related there. Now, the group that published this very recently, you know, I was a bit skeptical and started questioning, and association is not causality, and we're just talking about hospitalizations. There are a whole range of issues like, and in the discussion they go through very well some of the other possible explanations. So as a crusty old curmudgeonly professor from Sweden whose job is evaluation, I'm persuaded that the heart attack is good enough as you're going to get. It's as good as you're going to get for evidence. That, okay, I'm convinced. This is really intriguing, and I'd love to drill down into the data and look at male and female and start running some of the other variables and see, try to understand this, because you can only go so far with these very broad level analyses. Anyway, it's important to mention this, and I'm now going to move on. This is a side comment. Sweden, what we do is for each physician, on your screen, you will see the recent data for whether your HbA1c, body mass index, cholesterol, retinal examination, physical activities, for the patients that you individually manage. So in my Solna Ward Central, which is a health centre, the primary care physician can call up on his screen this, and you can immediately see with your list of patients in red which ones are out of control for the recent testing, and those that, and you can get a report of those you need to follow up, or which the nurse can follow up and look into. So I'm mentioning this because one of the key ingredients here is data. What I'm doing is looking the next 10 years. What I'm looking at is key issues like the increasing inequalities, but most importantly, the beginnings of the digitalization of health. Healthcare is being pulled kicking and screaming out of the Stone Age and beginning to enter into the world that most other people inhabit with data and digital technologies. The next 10 years is going to see phenomenal changes in these areas. And the things that we can do with the data and the data analytics and AI is going to transform healthcare. So that's number one. It will do it even more so if you're able to pool your data and work together with the data. The second thing is the cooperation between different health systems that normally compete and different physicians' organisations, and to find ways to cooperate which do not damage you as businesses, but indeed enhance you as businesses. So I think there are tricky issues. And don't for a minute think that in Sweden there are not issues about data sharing from one hospital and the other. There are less of a commercial issue, but there are still tricky things about, well, you know, I'm not sure that we want to share our data because of patient privacy, etc., etc. Anyway, this is just a reminder of how crucial data is, but the other thing is the importance of having the programming and the visual displays so that individual physicians and managers and others can immediately get actionable information, bang, like that. And the key here is groups that involve clinicians, visual display designers, computer programmers, people that know the databases, and people who are good at linking databases, so that you can deliver to customers actionable, comparable information that they can work with and do, that is credible to them. And it's that bit that's often missing, is those design groups that say, okay, here's the data, what we need to do is convert that through computer programs and visual displays into actionable data at the time and place that people need it. And this is, I know this looks a bit clunky, but it's in the direction that I think we need to do. In fact, I need to ask, how many of you know whether you're, well, does this happen in the States? Are you able, as a physician, to get a printout of basics like HbA1c and weekly printouts and that, and have alerts like that? Okay, so I think I see about 10% nodding. I don't know whether the other 90% is, well, I don't know, or whether it's no, we can't. I know for sure we can't. So anyway, we'll come back to that later. Incidentally, this comes from we have 106 national clinical registries. This is the primary care national clinical registry, which pulls in data from other databases to be able to present it in that way. So really what I'm saying is there are all these national registries, but what has to happen is to make the data work for you is that you have to design and have the software to present it in this way, to pull it in and link different databases like that. Now, for reducing heart attack, stroke and diabetic complications, score 0 to 3 how much your service is using these 3 evidence-based practices. I'm not going to ask for votes of hands because people may know their counterparts from different health systems and there may be, you may not want to go public on. So in a sense this is a rhetorical to ask you to score how good do you think our people are doing on this rather than having it out in public. Are you using effective clinical interventions for heart attack, stroke? So really what I'm saying is, of all the physicians, what percentage are using university best practice interventions for that? So would you say it's like 50% of your physicians consistently hit all of those guidelines, or would you say actually no, it's more like 90% of our folks are doing that consistently? And another question is, are we able to answer that question? which is an important one. So maybe we can come back to those comments and discussions later, so make a note of your thoughts on that. Now, where I'm coming from, public health, I've done a lot of work on integrated care, clinical care coordination. One of my conclusions is a patient's health is as much affected by how the different providers work together as it is by the individual skills and competence of each individual provider, especially for chronic illnesses. So what I'm saying is, often the patient's health, the total is less than the sum of the provider's parts because it's not coordinated. And there are obvious examples of this where the patient is confused by different advice from different providers. So coordination. Now, are you using effective clinical care coordination approaches? The obvious ones is a team-based approach or a care manager supported by connected electronic medical records. Are you using, there's probably about 5 or 6 ingredients for effective clinical care coordination. Do you know the research on this, and are you using it, especially for multimorbidity and moving towards patient-centered integrated care? Patient-centered medical home is along those kinds of lines. Again, rhetorical, do your score. How good are we doing on using best practices in coordination? And what are our systems for making that happen? Thirdly, are you using effective social interventions? For example, disease management approaches which pay attention to the affordability for the patient of meeting the requirements, ensuring they're getting their various eligibilities, welfare and other eligibilities, and also ensuring they're part of peer networks that provide social support and social accountability with people that they know and respect, those sorts of things. Again, is your organisation using these effective social interventions? Do you even know what that might be? And is it because you're funded in a way which doesn't reward you for doing those sorts of things? And we'll come back to that. Now, last of all, coming from where I come from, is this is evidence of the effectiveness of a practice. We also have evidence of effective implementation methods. And it's not just training. There are 93 different, implementation sciences now classify 93 different behavioural interventions. And usually for a particular change or improvement, you need to use a combination of behavioural. Typically, yes, you do training, but then you have practice, then you have regular feedback compared, and you often have financial incentives. Those kinds of combinations are extremely important. So what I'm saying is a science of implementation which gives you evidence of effective implementation. Are you using effective implementation methods for any of those to make sure that the other 50% of providers are actually enabled to take up these new better ways? So I'll leave you with those questions. We can come back to that. And I'll do a quick summary, and I've got probably about 20 minutes, maybe a bit less if we want questions.
15
summary.
minutes and then 15 minutes of Q&A.
15. Okay, well I'll go really fast. Best practice can be effective infrastructure. The research shows that you will get more physician partnership with strong leadership. But the problem with a lot of the research is that, you know, if we could get leaders like that with those, meet all of those requirements, I mean, there's no human being on planet who can meet all of those charismatic, respect, etc., etc. So ordinary mortals who can do that, or with a bit of training and they have the time, they can do it. Data for credible comparisons, that's a key ingredient for doing this. And then the incentives. I wish I had more time to talk about budget impact analysis, which is crucial for showing the business case, because it gets us into cost and savings sharing arrangements. And an ACO is essentially one of those. And the last thing is, it's not scale up, because that suggests you just copy exactly. We know to implement effectively, each site and place has to do local adaptations. How do we adapt appropriately, and how do we know that our adaptation is effective? There's more on that later. So I'm going to go really fast. Implementation science in 2 minutes, all right? So, this is Mary. She has obstructive airways disease, heart disease, stable at home on her medications when her son takes her to the primary care physician every 3 months or so. Incredibly independent, strong feminist, one of the first British feminists. And crucial is Matty, the unpaid motivational coach and security guard. This animal here who can see off foxes with a vengeance. And here this animal is guarding Mary in her garden, which is very important to her. And Mary, who lives in southern England, can keep a rose flowering every day of the year. How does she do this? What's the trick here? Now, this is no academic. This is an intensely practical person who had words to say about her son, who suddenly got into books and academics in a big way. The first part is the seed. And Mary knew you had to buy the seed from a good garden centre. And she knew the places that sold good seeds. They maybe cost a bit more, but you're off with a chance with a good seed. That is the evidence-based practice. Another ingredient is the gardener. And that's Mary. And that's your project teams and this group here. How you plant and nurture these practices and how you implement them. But the third ingredient is the climate and the soil, because some of those roses did not, quote, do well in some parts of the garden. Some of it was the sun, but some of it was the soil that actually varied tremendously in the garden in terms of the, oh goodness, she did explain it to me. It's something to do with acidity, and you used a pH, I don't know. So, my point is, it's the evidence, but the evidence alone changes nothing. The implementation is the crucial thing. But also, you won't stand a chance if it's the wrong climate and soil environment as well. And this is John's 10, 20, 30, 40% successful. It's actually 10% of his success is the strength of the evidence. 20% is your local leadership, 30% is a good project team with the right people on the team, trained and using project management techniques. But 40% of your success is the wider regulatory and financial environment. If you're continually financially punished for doing this change, it will not live, it will not sustain. If the regulation isn't right, but also if the climate and soil, if the culture of the unit or the physician group is just, well, that's not how we roll here. It's just not done that way. Then it won't grow and sustain.
And so this is the sort of the social science and implementation merger that I put together. And